It infects the red blood cells. The red blood cells then break open, spread out more protozoa, and it's this like terrible cyclical repeating event until the person is either cured, treated, goes into a chronic state, or passes away from it. So we're just going to talk about this for a little bit, and then we'll see the slides. The slides will mirror what we're going to talk about, but unfortunately, as I've explained, I can't update a lot of the slides, so we're just going to kind of like try to make it as useful as we can. What happens with malaria is when people get infected with it, it's a mosquito-borne vector. They take it from somebody else, they bring it to us. Of all the Plasmodium species, only 5 can impact humans. So when those get into a human's blood, it goes to the liver. Inside the liver, it goes from the liver into the bloodstream, but very specifically into red blood cells. As long as it's inside of red blood cells, it's not a problem. But the problem is these little protozoals grow and manifest, and they break open all the red blood cells that they're in. So the individual, from all those cells breaking open, will have intense chills, intense fevers, really bad symptoms, and then all of those protozoa that just broke open out of the blood cells get sequestered back into the liver, to which they then get back into the bloodstream, and it's this exponential reproduction type of system where it just grows and grows and grows until the individual is completely anemic from all of the blood cell lysis and either passes away or gets better. Of the species, one specifically is very dangerous because it is a little bit more toxic to the red blood cells, and it impacts all of the red blood cells. The other ones typically only impact immature red blood cells, so it's a little bit more limited on what it attacks, and it isn't quite as toxic to the body. The classic presentation of malaria is a cyclical fever illness. So if you have a patient that talks about, man, I got these crazy bad chills, I was freezing cold, and then all of a sudden I had this terrible fever, it was super high, bad headache, bad muscle aches, and all of a sudden it got better. And I was better. And then it's kind of like repeatable pattern. Then 2 days later, happened again. It was just worse. Chills, fever, I was sick, then it got better. Chills, fever. That is the cycle of those malaria protozoa getting into the liver, then the blood cells lysine, then back into the liver, and it's getting worse each time. That cyclical history, in conjunction with a history of, say, travel to an endemic area or mosquito exposure, should be a huge glaring red flag that malaria is at play. And then we can go and test for it. There isn't a lot of great tests for malaria. The diagnostic test of it is a blood smear. They'll talk about you can do a smear. They'll actually take the blood smear, they'll put it onto a slide, look at it, and they will visualize the protozoa in the blood. That's how they diagnose it. Now, is there any guarantee that they're going to grab blood that has the protozoa in it? There's not. And so they'll actually do repeated serial blood smears until they diagnose it. They can do either a thick smear or a thin smear, and that's exactly what it sounds like. Big, thick drop of blood on the slide, or they can smear it a little bit thinner. Which one is more likely to have visible protozoa in it, the thick or the thin? More likely to have it in it. Because there's more blood, right? But will it be more difficult to see through that thick blood into what type of species they have? It is, right? So the thin smear is where they can actually get into what species they're seeing of the Plasmodium. So there's value in both the thick and the smear. They just do a couple of different things. There is prophylaxis treatment that can help, and there is treatment that can help when there is an infection, and we'll go over both of those. The best thing to do is to not get malaria. If you can, don't get malaria. Problem is, as we just realized, people who are on chemoprophylaxis or medical prophylaxis, it's not a well-tolerated medicine. It hurts, doesn't feel very good. You got to remember to take it every day. And we're asking, especially in the military population, otherwise healthy individuals, to take a medicine that makes them feel crappy while they're in a deployed environment trying to do a mission. It just isn't super well tolerated. Living in Alaska for what we did, the mosquito is the state bird because it's so huge. I hated bug spray, and so we would commonly wear nets around our head, like those thin mosquito nets, just stick them on our hat and then around their collar. Those worked great. I'm not saying that anybody needs to, but that is a pretty good option if somebody doesn't want to take the medication, doesn't want to spray on the deep bug spray. The nets work really well as well. So that's what we're going to talk about. So now let's go into the formal part of the lecture now that we kind of had the informal conversation about it. All right. This slideshow has a lot of epidemiology stuff in it. You guys noticed from the first two tests how much I care about epidemiology, right? And I'm not telling you that it's not important, but we are looking at this malaria from a clinical perspective. How can we diagnose it? How can we treat it? How can we prevent it? All right, Plasmodium is the genus, 156 named species, and you can see the 5 that are italicized there. Those are the ones that are impactful to humans. Those are the ones that we worry about. Falciparum is the bad one. It's a really bad one. If somebody has Plasmodium falciparum, they're going to be increasingly sick, very difficult to treat, and if they're not treated accurately and aggressively quickly, high likelihood of a bad outcome. Vivax and Ovale are much more common, however, much less problematic. So they might take a little while longer to diagnose or recognize the symptoms and diagnose, and a little bit more treatable. Malariae and Knowlesi, kind of right there in the middle level. But Falciparum is the bad one. Vivax is, I think Vivax is the one that people is known to be the most common. We see the most of it. All right, these are some factors that help it with the epidemiology. I don't expect you to know that, but it is reasonable to be familiar with it, right? If you tease out in the street that somebody went on a tour to Africa, it was tropical, a lot of mosquitoes, we got bit by a lot of mosquitoes, and now these have these terrible cyclical fevers, malaria should be super, super high on your differential. Okay, here are some differentiating things. However, none of these are differentiating enough to just be like the thing that makes it one of these species versus another. But Vivax, most widespread, Falciparum, in the tropics, malaria is same as Falciparum. You guys can read that, you're smarter than I am. All right, so here's the pathophysiology. We talked about this a little bit. The patient is exposed to it via a mosquito bite in an endemic area. Those sporozytes, they migrate to the liver, into the hepatocytes. From the hepatocytes, they get into the red blood cells. Within a few days, those erythrocytes rupture, and then the merozoites, which are the baby ones, they are now spilled out into the bloodstream. They go back to the liver, they're sequestered, they go back into red blood cells, and this is exponential growth and parasite burden within the body. Some of them are gametocytes, I mean they can undergo sexual reproduction, but for the most part, they kind of break apart and reproduce through the pathophysiology we just talked about. They can create what they call hypnozoites. These are living malaria protozoa in the hepatic tissue. And this is why a lot of them will become chronic. They can't ever get truly cured because they don't go on treatment long enough to kill the hypnozoites in the liver. And then different times of their life, they'll kind of have a relapse from the hypnozoites that just decide to flare up. All right, it says here, and you see the big word critical there, history when it comes to malaria diagnosis, the actual history is just so important. If you can tease out, again, travel or placement in an endemic area, exposure to mosquitoes, and now they have the kind of standard cyclical fevers, very, very high likelihood you have malaria. All right, the incubation periods, you see here different days. Are these days really far enough apart on average to say you have one or the other? You really don't. So while it is helpful to kind of say, all right, you were exposed 4 weeks ago versus 2 weeks ago, you need the blood smear to differentiate the species. All right, the periodicity of the paroxysm of the fever, or in other words, that cycle, this is not diagnostic either. We cannot differentiate the species based on how far apart their cycles are of the fever, but it is kind of common for every hour or 24 hours, the Knowlesi one to have its cycle of fevers and chills, about 2 to 3 days for the others. This is not obvious at the initial infection, but it becomes much more rhythmic as the malaria produces and spreads throughout the body. There's a couple stages here, and you can kind of see this diagram and the different species amongst them. Now this is not a hard rule. This is just an example of what we're talking about and some commonalities. And you can see on the left-hand side this bulleted febrile attack. And this is very, the paroxysm is predictable, but the actual spacing of it is not always super predictable or diagnostic. But if you see somebody that goes from a cold stage where they have that intense cold, that severe shivering, a lot of that is from that red blood cell lysis with the protozoa spilling out. Then you go into a hot stage, and so they'll have this dry, burning skin, really bad headache, that can last for several hours, and then from there they just start sweating profusely. And this is not, I feel a little sweaty, like they're drenching through their clothes. This is very, very problematic sweating. And if you were to add up all that timing right there, you're looking at like a day at most, right? Like less than a day if you add it up, but a day for somebody to go through that. That's a lot to go through in a day. Something that cold, to that hot, to that drenching night sweat, back to normal. That's a very robust transition. So a lot of times, even the fact that they are having these repeated symptoms of chills, fever, and illness, and then good, and then back again, sticks out to the patient, and they'll even come in and be like, man, this is super weird. I don't know why I'm going through all this. It can be nonspecific symptoms, but a lot of that is just from that generic immune response creates a lot of these nonspecific symptoms. And naturally, you see the bottom there, non-immune patients and or immune compromised, they become really sick really quick. All right, falciparum, I already said, is the worst one. It's the super bad one. We don't want falciparum. It's the bad guy. Falciparum does a couple of different things that makes it more problematic than the other ones. Falciparum, it likes all red blood cells, not just erythrocytes. So we'll get into adult red blood cells, older red blood cells, baby red blood cells. It does not differentiate, it doesn't care. So it just has a better ability to replicate faster, more exponentially. The other thing that falciparum does is somehow it takes the red blood cell itself that it's in, and it creates this stickiness to the red blood cell. So now when that red blood cell gets into smaller arteries, and those smaller arteries in the brain, the eyes, the heart, peripheral vasculature, it clogs them up, and it creates an occlusion. When arteries can't have blood flow through them, what happens to tissue distal to that occlusion? It dies, right? And so we get this constant pain, excessive pain, and ischemia problems because falciparum is creating this occlusion because those red blood cells are being sequestered into these arteries, creating an occlusion. And it's just exponential. You know, you'll have the first wave of where all these red blood cells lyse, spits out the protozoa, goes back to the liver, goes all the way to the red blood cells, and all those red blood cells that have falciparum living in it are sticky. So the more sticky red blood cells you got, the less work it has to do to occlude arteries. So you'll get stroke-like symptoms, you'll get meningitis-like symptoms, you'll get seizures when it gets into the central nervous system. You'll kill your kidneys, it can kill a peripheral tissue, hurt the heart. There's a lot that happens with falciparum. And they call it microvascular sequestration disease. In other words, all those red blood cells are being sequestered together because they just stick. I don't know why they call it sequestration versus like a clot. I think it's because the clotting cascade has not truly kicked off and created the issue. But either way, the occlusion of the blood flow is the same thing that's happening. If every red blood cell is being infested with malaria and continually causing them to lyse open, what would we see our H&H do if we were to draw a CBC? Way down. So you also get incredible anemia. What does the body need red blood cells for? Carry oxygen and nutrients, gas exchange, etc. It now no longer has the ability to do its normal job as well. So not only are these individuals not getting appropriate perfusion, they don't have the red blood cells needed in their body to do the job, and so you also get severe anemia with falciparum as well. Cerebral malaria, and that is exactly what it sounds like. When that malaria gets into the central nervous system and it gets into the brain, that's when it's going to cause the most significant problems. Comas are possible, seizures are possible, stroke-like symptoms are possible. Now, we already talked about anemia, renal failure, pulmonary edema, all of those are capable, all secondary to falciparum because of that sequestration stickiness of the blood cells. In pregnant patients, a huge increased risk of morbidity and mortality, fetal loss, prematurity. It can also get into the spleen, bivaccino valley. get into the spleen, and it can cause splenic growth and or rupture. There are some non-diagnostic labs. And what that means is, do any of the labs that you see here on the slide diagnose us with malaria? No, but are they helpful to care for the patient? They are, because it helps us give us an understanding of what the patient's status is. So if we do a CBC and we see significant anemia, decrease in haptoglobin, and we know that malaria is not a differential, we know that they are needing something to replace it. Look at that. There's no eosinophilia. What do we typically see eosinophils go up with? What type of infection? Parasitic, and we have a parasite here, so that's unique to malaria. We don't tend to see a lot of eosinophilia with the malaria infection. Acute renal failure, especially if we have a patient with G6PD deficiency, or that's something that we screen for in the military, which is great that we screen for it, because the anti-malarial medicines can increase the risk of G6PD crisis, as well as malaria itself. But it talks about acute renal failure. Any idea on why we might get acute renal failure with falciparum? The sticky blood. Is the vasculature inside the kidneys nice, big, thick, and wide open, or is it like I-35, all congested? Right? It's super small. It's microvasculature, and it's just going to cause a lot of damage to the kidneys. Hypoglycemia, when I started researching this and trying to get back familiar with it, I was like, that's weird. Why is it hypoglycemia? And the answer was quite simple. You have a whole lot of things living inside you that never was before, and they need sugar. They love sugar. So they absolutely consume the carbohydrates within the body. And so if the protozoal infection, the malaria infection, is consuming all of the sugar, the blood glucose, does the body have what it needs? It doesn't. And so you can also get somebody quite hypoglycemic if they have a malarial infection. They're talking down into the 30 to 40 range of blood sugar level. If you aren't as familiar with blood sugars, that's the, oh crap, this person's about to die blood sugar level. That's pretty low one. All right. These labs, this slide is just kind of telling us if we see labs that are getting to this level, it's a pretty bad prognosis for the individual. But that should be pretty straightforward, especially as smart as you guys are. Renal impairment, if you got a creatinine above 3, if you're acidotic, if they're jaundiced, which means the liver is actually being damaged now, if they've got a hyperlactatemia or hypoglycemia, all of those are signs that the parasite load inside the body is so high, it's absolutely just wreaking havoc on all the internal organs, as well as the nutrients needed for the body to survive, as well as killing the red blood cells, creating the anemia. Very, very poor prognosis if we get to this level. And even, it says on the bottom, hematologic features, if we just start to see like signs of gross parasites in the blood, there's just nowhere for them to go anymore because there's so many of them. So just parasitemia is what we're talking about. All right, we talked about this a second ago. To diagnose malaria, blood smear is how we diagnose it. So we can do thick smears and thin smears. We want to do them a couple of hours apart. Why a couple hours apart? Because of the cycle we just talked about, right? They'll come out of the blood cells, then they'll go back to the liver, live there for a little bit, back into blood cells, open up back to the liver. So we want to do them, at least 3 of them, several hours apart, because we are actively trying to get blood that has the malaria in it, if it is there, so that we can make the diagnosis appropriately. And it tells you that the highest yield is soon after a fever spike, because it's kind of tracking that immune response of the body, trying to fight it off. So those blood cells should be present with a lot of bacteria or protozoa in them. Thick smears are more sensitive, and we talked about that. It's because it's a little bit more blood, better chance to see something, but the speciation or identifying what species is a little bit more difficult. Thin smears, a higher risk of not catching the malaria in it, but if we do catch it, a little bit easier to recognize what species is present in that individual. And parasitemia, talk about parasites in the blood. We talk about how many parasites per 1,000 red blood cells. Just some pictures here of malaria investigation, slide preparation. You're welcome to read through that. There's an example there of a thin smear versus a thick smear. Yes?
So just to clarify, if you do like the slide stuff, you'll see the parasites. You won't see like in a CBC eosinophilia respond to that?
No, not necessarily, not this one. Yeah, it's pretty unique to malaria, and so that's why kind of understanding that, and you're looking for it, you might automatically say, oh, I don't see eosinophils, so I'm not worried about parasite anymore, or like malaria anymore. We just need to know that malaria does not typically cause eosinophilia, so we have to have that higher, what we call index of suspicion, and go look for it. And that's why we pull multiple blood draws to do the smears to increase our chances of catching it if it is there. And we see it, I say we, not me, a pathologist visualizes it underneath the microscope. There are some dipstick tests, and these are just kind of at-home tests. They're not necessarily looking for malaria, but they're looking for byproducts of malaria infection. I actually looked it up last night, and the Binax now, still available, still could be purchased. So there is, and you can see they're 95% sensitive, 94% specific, so it's a pretty decent test. But again, it is not truly diagnostic. To truly diagnose them, you gotta have the smears that sees it. And that's why that next bullet there, need to confirm negative results with Nickerton smears. There's a picture of the card. I don't know why this slide's in here. Just kidding. Just the introduction to prevention versus treatment, right? So prevention, prophylaxis, we're trying to keep somebody who doesn't have malaria from getting malaria. And we know that if somebody is in an endemic area with exposure to mosquitoes, higher risk for getting it. And so if we can predict their travel and their location, we might be able to help them prevent getting it. There's not medicine that's 100% effective. It does help, but it's not always perfectly followed. Prevention of mosquito bites is the most effective, so mosquito repellent or just clothing over skin or nets over skin is a great prevention. All right, here's some medication options for prophylaxis. And again, those of you who have maybe had to be on before, if you probably remember correctly, they'll tell you start taking this a week before you go into theater or 2 weeks before you go into theater. Then you're taking it during the whole time, and depending on what the plan is that your clinic follows or your preventive medicine team follows, sometimes you can stop a week after you get back or a couple months after you get back. It just depends on what the medication was that they put you on. And this slide kind of talks about that. Different options here, when you start them and how long to be on it. I thought this was interesting. Doxycycline, I'm a big fan of doxycycline now. Doxycycline is an option for prevention, and I was like, well, why doxycycline? That's an antibiotic, and we're treating a protozoa, right, a parasite. And doing some research on it, there is an organelle inside malaria that synthesizes similar to what bacteria does. So doxycycline, being an antibiotic, can prevent the synthesis of that organelle as well, which can functionally help prevent malaria also. Even though it's an antibiotic, there is a role for it in that reason. Not because it's true bacteria, but because there is some overlapping commonality with some of the structure of it. Yes?
It's maybe a stupid question, but normally I guess like when you draw like CBCs and everything, you do a ramen too. Is this something they would have to go directly to the lab to like do the smears? Or is it something you can collect in a tube and send it to lab and then they would do smears there?
It's not a stupid question. I just don't know the answer. My thought is, and I'll look it up. They would pull the blood and put it right on the smear right away. That's how we get it out of the vacuum tube right away. Yeah. I'll look it up. I'll get a better answer for you. The truth is if you're looking for this, they're probably sick enough that they're sequestered. The patient is sequestered in a place where they can get the blood out and then put it onto the smear pretty quickly. No, that's not a dumb question at all. That's a good question. The only dumb question is the USA hockey team that just won gold the best in the world at all? Obviously they are. So. That was great. Anybody watch the hockey game on Sunday morning?
Oh, yeah.
Oh my gosh. That was a lot of fun. All right, I'll let you guys read through these. There's no hard answer as to which one is the best, the right, or the worst. Different clinics, I worked at several different clinics now, all of them had a different plan for how they do prophylaxis for malaria. As long as you have what's available to you, the patient is a good candidate for it. You kind of go over the risks and benefits with them, the importance of taking the medicine so that they decrease their risk of getting malaria, and then they come back and they come off of it. And a lot of them they will take past the time of return as well to keep it in their system to help prevent something that they may have been exposed to. A lot of our following slides here are talking about a lot of military specific stuff, and that's not wrong because our population is one that ends up in endemic areas a lot. And so as you work with your troops and or or your military personnel, always be ready to help get this prescribed for them if they need to. And then there is some people that will go on presumptive anti-relapse treatment or PART. And this is to help prevent those hypnozoites from kind of growing again and getting back in the bloodstream and kind of reinfesting them. And a lot of this has to do with, typically it is poor compliance to the prophylaxis plan. They didn't keep the malaria from growing like or dying like it's supposed to. All right, terminal prophylaxis. This is eradication of persistent hypnozoites. Tafenoquine is a good one. Primaquine is a good one. This is treatment. So when you're treating something, we do actually, this is meaning we've now diagnosed somebody. This is not a prophylaxis, terminal prophylaxis issue. This is somebody who has been infected. We have them in front of us. We've diagnosed them. We need to know what species they have so that we can treat it correctly. And then, of course, we would address the actual organ damage and or system damage that is going on with them as well. It says prophylaxis drug, don't use the same dosage, and all it's getting at is to prophylaxis or prevent it. It is a different dosage than if you're using the same medicine to treat it. And there is a difference between chloroquine sensitive and chloroquine resistant. Chloroquine is a pretty common one for people to use, both prophylaxis as well as the treatment of it. And there is an IV medication, artesunate, that can be helped if it's a pretty severe infection as well. You can monitor the treatment by continuing to take blood smears to see if the parasite load has decreased. And we should absolutely see that parasite load start to fall as they are on treatment for it. See that bottom bullet, if we do not see appropriate decreasing of that parasite load and or remediation, the treatment plan is not working, and so to reevaluate that and consider changing the medicines. Glucose control, we talked about how they can become hypoglycemic, so you want to manage that. We talked about how especially falciparum can cause a lot of central nervous system stuff. Monitor for seizures. And don't give steroids. Steroids make it worse. All right, relapse or reoccurrence. This is just some information here. Vivax and Ovali, a little more frequent in temperate regions. Incomplete treatment is another possible cause or risk factor for people having a recurrence. Reinfection can happen if individuals are treated and then get re-exposed to it again. They can be reinfected. And sometimes you have a low-level infection, something like Plasmodium malariae. It can be so low level that it's not even detectable, and they still have it. So they can have it for several years without ever actually being able to diagnose it. You see that one on sickle cell disease. If they get malaria on top of sickle cell disease, those blood lysis can cause a significant issue very quickly in the sickle cell patient. Diagnosis there. Our differentials there. I won't ever ask you a question, what are the differentials? Just kind of some things that it can mimic a little bit. A lot of this talks about malaria history within the U.S. military. Not wrong to know or read through. I'll let you read through that if you would like to. That's it for malaria. It can be a daunting topic to cover, but if you were to take a couple of minutes and kind of just treat out malaria, several species, only 5 affect humans. Of those 5, 1 is extra super bad. Others are a little bit less bad. What are some symptoms? What are the cycles of symptoms that can be present with it? How can we prevent it? Some of those prophylaxis plans. How can we diagnose it? What are some complications of it to monitor for? And then how can we treat it if we have somebody to treat it with? It's not as bad once you start to kind of like distill it down. 55 slide deck is a little bit overkill, but there's a lot of extra information that was interesting to have, but not critical for our need to know. Okay, are we okay if we start the next one real quick and move on, or do you guys need 5 minutes? Good. Pet-associated diseases. There are a lot of slides in here. We're also going to kind of like distill it down for what we need to know. There's lots of pictures in here. Again, I'm a sucker for pets. I really like them. Anybody have any cool pets? Like Rocky Balboa had Cuff and Link. You all know who Cuff and Link are?
Turtles.
They're turtles. They're Rocky's turtles from the movie Rocky Balboa. Pretty cool. He still has them. They're still alive. I like Rocky Balboa. It's pretty cool. All right. We are not a surgical class. We are not an orthopedic class. And so a lot of these talk about what to do with the trauma associated with, say, a pet bite or an animal bite, and that's okay. That's not going to be the focus of our conversation. Our conversation will be the infectious side of what can happen. Say a pet or animal bites somebody. Bites or scratches. Animal bites. Yeah. I tried to update this with a picture of my dog because she's way cuter, but it wouldn't let me. All right, here's some statistical stuff about animal bites, dog bites. You can read it if you want to. Let's talk about getting the history of it. Where it's most likely to occur. There's some pictures of it. And history taking. All right. There are some things that are quality pieces to take away from an animal bite history. What the animal was, value added. If they know the vaccine status of the animal, very value added. Because if they don't know the vaccine status, you could be at higher risk for, say, a rabies exposure or something like that. On top of that, where they got bit is pretty important. Did you guys happen to see on the slide the part of the body that tends to be bit the most?
Hand.
The hand. Probably because idiots like me try to pet every dog they see, and not every dog they see wants to be petted. I believe that every zoo is a petting zoo if you're brave enough. So there are people who are going to get bit a little bit more. The problem with being bit on the hands is the hand has so many moving joints. All of those joints are their own capsule. They all have got their own ligaments, their own muscles that come with their own synovial casing. That is a lot of damage that can happen in a small space. That takes relatively little trauma, swelling, pus buildup to cause big issues like compartment syndromes or tenosynovitis or get systemic or something of that nature. So it's really not the power of the bacteria itself that's being infected. It's the fact that those teeth can deposit that bacteria deeper and into smaller compartments within the hand that can spread a little bit more. So lots of risk for retained foreign bodies, broken bones, torn ligaments, and or bacteria that gets into smaller compartments that creates a much bigger problem than it really would be. You guys have had a lot of stuff. Have you guys talked about flexor tenosynovitis yet? Of the hand? That's a bad one. That's a real bad one. It's basically compartment syndrome of a finger, and it can absolutely cause the finger to need to be surgically removed, stuff like that. So if you have a bite wound, one of the best things that can be done, especially pre-hospital, is significant irrigation. Get as much of that washed out and cleaned out as possible. Running water is great. The patient can tolerate soap and water. That's also really great. That can help a lot. Then this is talking about kind of some work that we can do. On the infectious disease side, not super as interested in all of the CTs, the ultrasounds, the x-rays, because we want to treat the infection, but it is something that's part of the treatment plan and workup as well, looking for anything that's broken, torn, deposited, retained, etc. We can definitely do a culture and sensitivity of the wound, and then if those patients have a bad outcome, a lot of these other labs following them is reasonable as well. Copious irrigation, especially under pressure, is great. If we are going to treat, especially a bad one, you can kind of see about 3/4 of the way down there. Polymicrobial coverage, especially for staph and anaerobes, is good, only because we know that it's not that staph lives on dogs' teeth or animals' teeth. It's all over the place, right? And that bite is actually taken now and pushing that bacteria that's just living on the skin deep into their tissue. So clean it out as good as possible. And a tetanus prophylaxis shot, if they haven't had one or not up to date, is great as well. Rabies has to be considered anytime you have an animal bite. That was always probably the first question I ask is the animal who bit you known to you? Do you know this animal? Is it your own animal, neighbor's animal? Can we get either if you don't have it, knowledge of their vaccine status? Because if they don't know it, especially if it's high risk, those individuals are going on rabies post-exposure prophylaxis, which is its own complication as well. All right, Augmentin is like by far and away the most prescribed antibiotic for an animal bite. Augmentin has great coverage for really common organisms associated with animal bites, and it also covers other bacteria or pathogens that can be put into it. When I was a PA student and I saw this exact same slide, because it's the exact same slide I was taught off of, I said, Augmentin sounds a lot like Dogmentin. So if dogs bite me, I want Dogmentin. Years later, as a practicing PA, I'm in the ER just chilling out with a doctor, an ER physician. He goes, do you ever know that Augmentin sounds like Dogmentin? That's how I remembered it. I was like, do you now, doc? You're a smart one. He thought he put me onto something. I was like, I'm way too dumb to be that far behind you. I am creating stupid ways to remember stuff left and right. But Augmentin, phenomenal medicine. A lot of people, and it's not just dog bites, but any trauma to the hand, a lot of them will go on Augmentin as well, just because that's such great penetration into the smaller joints of the hands for some reason, and it covers a lot of bacteria that can be there. Augmentin is a beta-lactamase inhibitor, i.e. penicillin, and that's one that's a very common allergy to it. So even though I don't have it on the board, I did some research, a lot of individuals will end up either on Bactrim or Doxy if they have an allergy to it. That's more just FYI. At that point, if somebody has a penicillin allergy, pretty easy to look up an antibiogram locally and know what to put them on. But Augmentin, drug of choice. Surgical intervention may be needed. This is a debridement if it's bad enough or it doesn't respond to antibiotics. A surgeon may need to actually take them into an OR, open them up, clean everything out, sew them back up, or sometimes they won't even sew them up. They'll just put some soft enclosure knowing that they're likely going back to clean it out a second or third time. So surgical intervention is completely possible with animal bites as well. Wounds on the hands, about 2/3 of the way down. Wounds on the hands or lower extremities, a lot of times they'll be left open because if you take something that an animal has bitten, even if they're antibiotics, and it's open, and you start to sew it shut, the risk of you sewing in an infection into that skin increases a lot. And so you can actually help propitiate a bad outcome by sewing it shut. So a lot of times they'll be left open and allowed to heal, and then they'll allow that wound to close by like a secondary intention with time. And then anytime you have a wound that's open after a certain period of time, a lot of times those will not get sutured up as well. This one's talking about animal bites. You see there, a wound older than 6 hours. Some type of a delayed closure is ideal, trying to keep that infection from being seated deep within that tissue. A lot of individuals that I worked with in the past would use 12 hours as the cutoff from an injury, like a normal injury, like they slice their hand open with a knife or whatever. If they can get it sewed up within 12 hours, they're pretty comfortable with it. But dog bites or animal bites, we kind of lower that a little bit because we want to decrease our risk of having a pretty deep-seated infection. Some referrals or consults you can look for, and a lot of these will absolutely be consulted depending on where the trauma is. And even though we're in an infectious disease class, this is talking about this much more secondary to the actual trauma and location of the animal bite itself. Just an example here. Trauma to the face. And a lot of these are complications of animal bites. It makes a lot of sense, right? If we get a pathogen injected deep into the skin, depending on what the pathogen is, how deep it goes, or where it travels in the body, different complications can arise from it. And then as those complications arise, if we're unable to prevent them, we treat them accordingly. this is probably a good place to stop and take our break. Take a break, we'll get started at the top of the hour again. We don't have a lot more to go, so we're doing good.
Wave just like it's crazy, but like it's clearly on the page to make sure you know how to research for showing up here yeah. Like, am I going insane? Like, I mean, I have to. I know I have like military like yeah. Oh, you just randomly interact with school and it goes away? Yeah, that's it's bad when it hurts as soon as you go away. Then as we start stabbing, people start having issues.
I mean, it's possible.
Oh, God. I can't fly.
Nobody really gets that like 1950.
I was like 19 when I was heavy.
I guess alright, this is when we started making our strides and we started learning the language. And that was kind of like, we're done. We're done.
Like, it makes sense. First week, like, wait.
And he also said that they have like a counter of the he said that the max
More the merrier.
they only do so many because of lanes and so our whole class is like a whole day's worth of duration of
I don't know that we're admissions to be on the rock page.
The week before, like, I was medicated.
Exactly.
like you would say, I probably like compared on
Those lights, so basically have nothing to compare, but we're still talking.
So it's like, if they do it, they have to
No, we're not saying. I saw it.
18. We have a. Yeah, I think what's it?
I just started classes that actually lab, like lab.
We'll see.
Sorry.
Very good.
It's like
It's not gonna change my game plan. They're like Rory and Scotty and all this must be the same. I was like, it makes sense because you're literally rolling over the wall instead of back and having it
I can't make it much better than
I mean, you have a nice mind, so it's like, mine's pretty nice too. I spend like $100.
putter. I mean, I will admit, I have swung some of those. You can tell the difference. But it's like, I'm not playing competitively, so I'm not buying it.
I'll just dabble because I saw before they're always instead of the champions here, so it's like literally over spotless. And I was like, it just makes sense, like get more control, whatever. Or the stroke. I like that. It's the new thing. So they can.
Get a new set of irons, graduation, and then we buy myself a new driver. So my driver is shot. Or I just might buy a new head.
Yeah, just keep. What's that?
Like Cobra. Yeah.
That's why I haven't gotten away from two because I had one. 2 and 9 are GI 10. It's like just paying 2 months.
Is this cat scratch fever? Should start playing it. I've heard of it.
Don't even have a camel pattern on it.
Alright, let's get started. Go. I meant to show you this on the slide and catch it, so I just show you real quick. Pasteurella multocida is the most common pathogen associated with cat bite infections, but is not necessarily identified most common with dog bite infections because it can be pretty variable. Anytime I see the word most common, I circle it, alright, put it on the list to make sure I know later on. Alright, cat scratch disease. Anybody? Yes. So that one's referring to more of an immunocompromised patient, tends to be asplenic as well. So yeah. Yeah, the Pasteurella multocida, and I wish it was italicized, but that was the one that sticks out. Cat scratch disease. Just call it cat scratch fever. I think Ted Nugent wrote a song about it. I guess there's an internal conversation you guys have about Cinderella Man versus Rocky. I don't know how, because Rocky is better. So my sons and I watch guy movies Saturday mornings. Mama gets to sleep, we put on a movie that she wouldn't like anyway, and we watch it. So I let them watch Rocky several years ago, and they thought they were watching an action movie. And at the end of the movie, they say, well, who won? You guys remember who won the fight that Rocky won? Rocky.
Neither.
No, there's always a winner in a boxing match. Apollo Creed won, but Rocky became the fan favorite. And so we were like, you tell me who won. And so even they were like, I don't know who won. This is such a good movie. And I'm like, exactly. True maturation is when you realize Rocky is not an action movie, it's a love story. I'm telling you, go back and rewatch it. That dude's a good dude. All right, cat scratch disease. Pretty common. Comes from exposure to injury from an impacted cat, usually a bite or a scratch, and Bortonella henselae is the pathogen. Commonly it causes a rash or skin manifestation, but lymph node or lymph node enlargement tends to be the most common finding with cat scratch disease. History of contact with the cat, usually scratch or a bite, and then there's usually regional lymphadenopathy. So just think intellectually, what parts of the body are most likely to be bitten or scratched by a cat? Hand for sure. Hand, arm, and face. So people with cat scratch disease very commonly will get either cervical lymphadenopathy or axillary lymphadenopathy. It's very, very common. It's all obviously not pathognomonic. It can happen anywhere, but for whatever reason, there's a lot of facial, neck, or axillary lymphadenopathy with cat scratch disease. And we're going to talk about this in a little bit. Second bullet from the bottom, Paranod oculoglandular syndrome. This is crazy. Somebody gets licked, bitten, scratched in the eyeball, and now they get conjunctivitis, and they get an auricular lymphadenitis, and that's from a cat scratch disease as well. Rashes can happen. They're usually little papular lesions, and lymphadenitis can happen as well. It can last a long time. In fact, cat scratch disease is a very common reason for prolonged or chronic lymphadenitis or enlarged lymph nodes. Axillary nodes are very commonly impacted. After that, cervical, submandibular, and preauricular, all in that face and neck area, just because there's so much relation to cat scratches in that area. This is kind of that skin manifestation, those papules, pustules close to the area. Here's an example of some swollen lymph nodes, periauricular on this young patient. You see where it says FUO? You guys remember what that stands for block 1? I feel like block 1 was like 3 years ago, like look for a lifetime since block 1. Fever of unknown origin. A lot of times the exposure to the pathogen from the cat is not easy to tease out because it can be as simple as just being licked by the cat. Usually not like licked on the skin, he licked on like say a mucous membrane, the eyeball, the eyelid, or something like that. But a lot of times that history is not always as prevalent, especially if you look at the incubation time, it can take a little while to come on down. But prolonged fever without a source, or you get that fever of unknown origin state, cat scratch disease is very reasonable to have on your differential. All right, this Paranod oculoglandular symptom happens from the site of inoculation, like the eyelid or the conjunctiva. It can be a lick, a scratch, or a bite. Something from that cat is placed into a spot where it's not supposed to be. Patient develops conjunctivitis and ocular granuloma. Do you guys know what granuloma is? Yep, just this like heaped up pile of skin, inflamed skin on the eyeball. And then preauricular lymphadenopathy, and then it kind of just resolves on its own in a couple of months. Here's an example of eyelid with conjunctivitis. If cat scratch disease gets into the central nervous system, we've talked about this a lot, right? There's not a real big difference on what it does. The central nervous system comes with a lot of things, anywhere from headaches to muscle aches, seizures, and then Bell's palsy is written on this one, retinitis as well. Are you guys familiar with Bell's palsy? You guys heard of that one before? Right. It looks a lot like a stroke, but it's not a stroke. One of the patients I saw this last weekend when I was working had stroke-like symptoms, and I was like, "Are you having a stroke or do you have Bell's palsy?" She's like, "I got Bell's palsy." I was like, "How long have you had it?" She's like, 5 years. And I'm like, "You just been walking around with half your face not working for 5 years?" And so, yeah, Bell's palsy can last a very, very long time. Have you guys talked about strokes yet? You haven't talked, not even pathology, you guys haven't gotten to a stroke yet? So strokes, this is not across the board, but a very common good differentiator between Bell's palsy and strokes. Bell's palsy will in fact impact the entire face. Strokes oftentimes will spare the forehead. So they'll say stroke spares when it's talking about the forehead. So if you're trying to differentiate between somebody with acute Bell's palsy and a stroke, a potential physical exam finding if you ask them to raise their eyebrows, and they can raise them, but the rest of their face is drooping, good chance that it's a stroke. If they cannot raise both eyebrows and the entire set of the face is drooping with that eyebrow drooping as well, good chance it's Bell's palsy. Not guaranteed, but very common. All right, so labs and diagnostic options. The history and the physical is easily the best for cat scratch disease, especially if you can tease out that they had the trauma from the cat. And then you see the skin manifestations, the conjunctivitis, the lymph nodes, very common. There are some serology tests that can help, and then of course antibody titer to Bortonella would be helpful as well. If you have an immunocompetent patient, not a lot of treatment, meaning something directed at the pathogen is needed, it's pretty self-limiting. If you have something that's more impactful and you need a macrolide is possible as well, or helpful as well. And then the Paranod oculoglandular syndrome, very self-limiting. It's just kind of scary to look at, and Can be worrisome, but it'll get over in about 6 weeks. You guys remember conjunctivitis from HEENT? A viral conjunctivitis, remember where the which lymph nodes are most commonly impacted with conjunctivitis? It's always preauricular. For whatever reason, the conjunctiva, regional lymphadenopathy, is always right in front of the ear. So if you have preauricular lymphadenitis and eye infection, a lot of times it is either cat scratch or just a viral conjunctivitis. All right, toxoplasmosis. We've talked about this a couple of times, and there's 2 patient population that toxoplasmosis gets a lot of notoriety for. Do you guys kind of remember what those 2 are? Pregnant women is one, and HIV patients. Yeah, those two patient populations, if they get exposed to toxoplasmosis, a little bit more impactful. Otherwise, not as bad. But Toxoplasma gondii is the pathogen. Some people would have a little bit more impactful issue: fetuses, newborns, immunocompromised, which we talked about, and then pregnant ladies because they are the ones carrying these. Sources of toxo: ingestion of contaminated material. It does not have to be meat, but it can be. And you guys remember kind of the classic history of the pregnant person who has toxo? The cat litter. They have a cat, and they're cleaning out the cat litter box, and somehow they get that into their system from being exposed to the cat litter. All right, that's right. Feces from acutely infected cats, most commonly U.S. Undercooked meat. People find it in wild game. The 4th bullet down says horse meat. That's a meat I haven't personally tried yet. Anybody watch The Office? Is it? Okay. Anybody watch The Office? Remember when Dwight Schrute was like, I could harvest a pound of horse meat without killing the animal. He called, what do you call it, quarter pounder on the run or something like that? A cheeseburger to go, was it? I don't remember it. I was like, Dwight Schrute, you are pathologic on yourself. Anyway, you can kind of read through this, but a lot of undercooked meat, where the infection is, it did not get processed appropriately. Just talk about family members of people with toxo should be screened for it as well. They're asymptomatic in a lot of people. If you're a healthy individual or the patient's a healthy individual, typically pretty well tolerated. If they're immunosuppressed for some reason, it can progress pretty quickly. The immunocompetent host, in other words, the healthy immune system, has a mono-like syndrome. You guys remember with mono, got the throat pain, the shaggy exudate, and a really extreme fatigue, and that's kind of what you get with toxo as well. Immunocompromised patients, much more complications, especially if it gets into the central nervous system. It can cause a lot of encephalitis or meningitis, stuff like that. Here's a scan of the central nervous system, brain tissue with toxoplasmosis lesions inside the central nervous system. All right, signs and symptoms: if it's congenital, it can be very problematic early in pregnancy, and at birth, the individual can be seen with anemia, thrombocytopenia, jaundice, microcephaly, or hydrocephalus. If it's congenital, a chorioretinitis is a very common one. Chorioretinitis, what part of the body is that? The retina, so in the eyeball. And so if the retina of the individual is impacted, symptoms associated with vision changes are very likely. Here's an image of a retina that's impacted with chorioretinitis secondary to toxoplasmosis. That's just real bad, right? Like, you should go look at that. That's not good. An individual born with hydrocephalus secondary to congenital toxoplasmosis. Almost doesn't look real, right? Like just all of that fluid that's in that head cavity. All right. If they can find the toxoplasmosis organism in one of the body fluids, that's how they treat it. ELISA can help. We can also do some imaging of the head to see if there are lesions present as well. If there is concern for congenital toxoplasmosis, and amniocentesis can be done to evaluate for it. Asymptomatic hosts, typically not treated. If you have symptomatic individuals, you can see at the bottom there, if they have chorioretinitis and or congenital, pyrimethamine, sulfadiazine, and leucovorin are good options. And if they have an acute disease while they're pregnant, spiramycin is not a bad option. All right, acute toxo in the AIDS patient, pyrimethamine, sulfadiazine, and leucovorin again. And then you can see here suppression therapy, a little bit lower at the very bottom, it talks about sulfadiazine plus pyrimethamine. We're going to talk about closing class of atypical mycobacteriums. What's the most famous mycobacterium we've talked about so far? Tuberculosis. So Mycobacterium marinum. Marinum refers to what part or what kind of thing? Water. Mariner's water, right? And so this one is also known as fish tank granuloma. A lot of these conditions we're going to talk about here with the mycobacterium, they're secondary to skin injury that then gets exposed to the pathogen, and then it gets into the skin and causes a problem. So fish tank granuloma, these individuals are exposed to Mycobacterium marinum, secondary to salt water or freshwater exposure, and usually there's some type of injury that's already present or happens, and then that pathogen gets into the skin and causes granulomas. There's usually a papule or nodule at the wound site. Localized pain. There can be systemic manifestations, but it's not very common. And depending on where it is, if it gets a little bit deeper, you can get something like compartment syndrome or tenosynovitis, septic arthritis. We talked about that a little bit ago with the dog bites. Here's an example of the granuloma. Little lesion on the skin, got exposed to water that had it in it. It can be pretty painful. To diagnose it, or to evaluate for it, cultures are helpful. And we said already that Mycobacterium, very famous one is tuberculosis. Look at the bottom one. False positive PPD is possible if people have Mycobacterium marinum. They can possibly give a false positive for a PPD if you're evaluating for tuberculosis. Treated antibiotics are a great option. Clarithromycin with ethambutol or ethambutol and rifampin. Look how long they have to treat them for. A minimum of a month, up to 6 months, depending on the severity of the case. It can take a while for this one to get treated and eradicated. All right, Mycobacterium ulcerans. Just the word ulcerans, what do you think is implying of the skin's going to happen? Big, giant ulcerated lesion, exactly. It's an environmental pathogen, aquatic environments or domestic animals. And like I said, every zoo is a petting zoo if you're brave enough. Here's a picture of Mycobacterium ulcerans. Exposure to it from these animals or carriers, and there's an opening in the skin, it can get into the skin and create this very large ulcerated lesion. High clinical suspicion, because the earlier we can diagnose it, the better. So if you have somebody that comes with this giant ulcer and they have a history of a skin opening and trauma, then they were exposed to something that is commonly called a carrier of ulcerans, you can kind of just look for it really quickly. Then you can see second to last bullet there. Rifampicin, clarithromycin, or moxifloxacin for several weeks. And then even that last statement, a lot of treatment requires debridement and skin grafting. That should kind of give us a clue to how impacted this ulcer can be. Very deep-seated. Right, Mycobacterium leprae, also known as leprosy or Hansen disease. It's found in several places, to include the footpads of armadillos. Typically a respiratory transmission, a little bit different than the ones that we just talked about. Can have macular lesions, can have some erythematous nodules. Here's a picture of some of that as well. Here's some examples of different individuals impacted with Mycobacterium leprae. Gets into the skin, creates these big long ulcers or plaque-like lesions. The skin lesions will have a diminished sensation. They kind of impact the nerves a lot. Neurological disturbances, motor abnormalities. Ulnar neuropathy, especially with bilateral, high concern for exposure to Mycobacterium leprae. See at the bottom right, rifampicin, dapsone, or clofazimine. All of those are options for leprae. Mycobacterium chelonae, associated with soil, frogs, and turtles, can be found in water, soil, and aquatic animals. Again, skin and soft tissue infections. There's even some association with tattoos that some people have had because the ink was contaminated. It was used with the contaminated water. Here's an example of a tattoo that somebody got in that secondarily infected with Mycobacterium. Erythema, edema, and these violaceous nodules. There's one other condition we talked about with violaceous nodules. Remember APOC, right? And so this is different. They kind of overlap with each other. Tobramycin and clarithromycin are best coverage for it. And again, if it's a deep infection, several months of treatment might be needed. Leptospirosis, I think this is the last one we're going to talk about today. It's a spirochete pathogen, Leptospira. Most common zoonosis in the world. Distribution is worldwide. And is even becoming a much more emergent disease in travelers. Transmissions from direct contact with the body fluid of whatever acutely infected animal is. And it's not like we're trying to say that people are going out and being exposed to a bunch of body fluid, but those animals release fluids in whatever way to soil, water, and those individuals become in contact with them, and then they can get leptospirosis. There are two recognized clinical syndromes secondary to leptospirosis. One is called anecteric leptospirosis, very self-limited, mild, flu-like illness, and that's a bit more common. You see 90% of it right there. And then there's icteric leptospirosis. If we hear the word icteric, what should already come to mind? Yellowing, jaundice, or something, right? So if yellowing or jaundice comes to mind, which organ should come to mind?
Liver.
The liver, exactly. There can be severe illness. There can be multi-organ involvement, but a lot of times it can be significant liver impact as well. Which syndrome the individual will get when they get exposed to leptospirosis is really undetermined. It just kind of depends on what the body responds to it as, and obviously the health status of that person who gets exposed plays a role in what they actually get. Icteric leptospirosis, multi-organs get involved, really high temperatures, rigors, headaches, nausea, anorexia, cough, rash, muscle pain, all of that. And look how severely yellow this individual's skin and sclera are. Has anybody seen acute jaundice? Like, I'm not talking about the babies that are born, they're a little bit jaundice problem. Like, it sticks out, does it not? Was it the whole skin or just the eyes? Everything. Really? What was this condition? Oh, cirrhosis. When I was working in California, there was a VA patient that came in, like the gentleman just said, yellow everywhere, just head to toe, bright, looked like a highlighter was all over him. He had a pancreatic duct cancer, and so it was blocking all of the proper transmission of the bilirubin, and it just positioned itself all the way into all the skin. He needed surgery like immediately. All right, back on leptospirosis though. Isolation of the leptospires is the gold standard. Tissue or body fluids, commonly in urine, can help with that as well. And then, of course, if we want to evaluate organ involvement, we can do stuff like CBCs, liver panels, coag studies. That's not evaluating for lepto, it's evaluating for the impact of the lepto on the different organs within the body. If it's a severe infection, IV PENG is a great option. If an outpatient option is available, in other words, they're stable, doxycycline is available. And with that, we are done with today's lectures. Any questions? I think I have a due out for one question about how quickly we can get blood on the slides for the malaria. I think we got a couple more lectures this week with you guys. All right, cool. Ready? Great.